So, welcome to another edition of Help for Mothers. We are a podcast that aims to help mothers with health, education, love, and protection. And today I have the great pleasure of speaking to two mega experts in the field of helping mamas be comfortable, be prepared, be informed, and also address a situation at the end of pregnancy when a baby might be laying breech. So let's do intros first. Anne, can I ask you to introduce yourself? Who are you? Where are you? What do you do?
Sure. I'm Dr. Anne Lundquist. I'm in Southern California in the city of Orange. I've been a chiropractor for 30 years and seen pregnant women my entire career. I've always loved working with pregnant women and trying to help them have better outcomes and be more comfortable during pregnancy as well, because I think that all works together. And I love spinning babies. I love the ICPA. There's a lot of information out there and a lot of resources, both for providers, but also for parents.
Awesome. Thank you for joining us today. And we also have the great pleasure of having Caitlin with us. Caitlin, will you introduce yourself? Who are you? Where are you? What do you do?
Hi, I'm Caitlin Clarke. I'm also a chiropractor. I have an exclusive practice, which is just for prenatal and birth. And I'm in Santa Cruz, California, although I also do births in Monterey. I attend births also as a doula as well in Monterey, Santa Cruz, and Santa Clara counties. And my first doula birth was 30 years ago this year. and I've been
That's amazing.
Yeah, I know. I didn't do it all, I had other things going on in my life, so it wasn't consecutive, but yeah, 30 years. And I also do a lot of advocacy work and a lot of activist work as well. And I've been a chiropractor for 20-something years.
Amazing. Well, we're so happy to have both of you on the call and on our little presentation. It's so exciting. Today, we're going to aim to answer the question, what if my baby is breech? And so that is a worry for many around the United States, around the world. Babies don't always read the books. They don't always know the path to take that's generally easiest. And honestly, some of them have a wisdom we don't even understand, and that is the easiest position for them. So it's a very interesting and broad subject to try to unpack. And birthing people, mamas who come into this situation don't always have the benefit of lots of advice, lots of guidance, lots of research. And now, more than ever, with a shelter-in-place order in place for 95% of Americans, they can't get to the care that they want. They can't get to advisors or support, counselors or body workers. And so some of them aren't even able to get to their regular providers, as we've seen prenatal care diminished significantly. So this conversation is particularly important right now, but all the time, because babies will always be born, and some of them, approximately 2 to 4%, will not be head down at term. And so that's what we're going to chat about today. Let's start first with how do we even find this out? How would a mom discover this? Yeah, go for it, Anne.
Well, first of all, you might find out for the first time really late in pregnancy. Sometimes when things are normal, not in this COVID world we live in, parents won't be told until it's basically time to make a decision about, scheduling their C-section or scheduling something called a version, where they try to turn the baby manually. An obstetrician would do that. So sometimes people don't really even have an option for very much time, or at least they don't feel like they do. People oftentimes have more options than they are presented. What's kind of interesting is I was my mom's third child. I was her only unmedicated birth in California, and I was a vaginal breech. So I'm that small percentage and feel called to this work for sure.
That's awesome. Yeah, you started from the very beginning researching this topic. That's fantastic.
Set out, right?
That's awesome. Caitlin, will you tell us if a mom is seeing a chiropractor, would the chiropractor tell her baby's breech?
No, chiropractors don't diagnose position, but what we do is we work with them on learning how to belly map their own belly. So, and that's one of the things that the Spinning Babies organization that both Ann and I are very involved with teaches as well. So we can teach them how to kind of try to start figuring it out themselves in terms of the Spinning Babies belly mapping. And we can also encourage them, and we do. There's some, like, for example, most home birth midwives are checking for position all along. I mean, even before they can even feel position, they want to be checking for tone of the uterus and everything. So that's usually who refers earlier, are home birth midwives. And later is usually when we get more referrals from OBs, because it's just not part of their practice to be necessarily concerned about positioning that early. So what we do is, if we are working with people earlier on and they're not working with a provider who would necessarily be palpating a lot, we can encourage them how to go and talk to their provider and ask them to start doing that.
That's
and
awesome.
Of course, the only way to 100% confirm position, of course, is ultrasound. So there's still a
right. That's right.
still
That's what I was going to say. Oftentimes, a mom will find out that her baby is breech at an ultrasound, and of course, the really curious thing about the U.S. healthcare system is that when you go get an ultrasound, it's ordered from a primary care provider. So the ultrasound tech doing the actual scan can't give any medical information. So even though in the scan it might be incredibly obvious that there is in fact a head up under her ribs, the OB ultrasound tech can't usually confirm that. So moms will oftentimes leave like distressed without really anyone to counsel them, not knowing what really is the case. And the poor techs, I mean, oftentimes they'll be like, I can't tell you, I'm sorry, it's a liability thing. And it makes it so disorienting for those mamas leaving those OB appointments, going to find out theoretically at an ultrasound, but then going to the ultrasound and not being given the full information, or just being able to piece together what they can visually see on the screen. That's kind of their first diagnosis. So I want to start from that place, because even in high hands-on midwifery practices, we still always confirm the diagnosis with ultrasound. This is going to be the vast majority of cases are going to find out through the ultrasound. So I want to start with this place. From your both incredibly learned and long-time experience opinion, and clinical knowledge base, what's the first thing? Like, take us from that spot. Like, a mom is laying on the table. It's obvious her baby, that bump under her rib that she thought was the head, or that someone else thought was the head, is the head. The baby's bum is down in her pelvis. Take us through, like, what happens next first? What should she do?
I have to say that it's not so very different how you start out with a patient too, because we've got to go through our paperwork and our history and our consultation and specific chiropractic exam. But for that patient, sometimes they have some things that they'll say. They're getting kicked in the cervix. They're feeling a really hard bump under their ribs. They might say some things like that, and that goes with the belly mapping for sure. I always want to talk about the fact too that the baby has to choose, right? The baby's the one that chooses the position. So if we can add ease through using chiropractic care and some of the Spinning Babies techniques to add balance to the ligaments, we're going to give the baby more options, but they still have to choose.
Yeah, definitely. Caitlin, talk to us about the emotional situation that brings up for people.
Sure. Yeah.
You've dealt with many. I mean, you've gotten many a freaked out phone call at that exact moment. Tell us what happens.
Yeah, I field several phone calls a week, sometimes several in a day for people with breech babies. And so this is speaking more from my doula perspective. That's when I do these consult calls that would go a little bit differently than seeing a person for chiropractic. I usually work with them for both, but my first interaction with them is usually on the phone when I do get the freaked out phone call, very justifiably freaked out. What I try to do at first is help the client get grounded, to stop, take some breaths, and to start this really, it can be a very difficult process of making these big decisions sometimes with very little time. So it's important to stop and bring everybody back as much as we can. Sometimes many people are really in crisis mode at that point. So to strategize with the client about how can we first get you in a place where you can make good decisions and where you're feeling safe and cared for. What I have found is there's a couple things that I talk to them about first. One is when you take I've done a lot of training in trauma and grief care, especially surrounding birth. But what I found is, and I know that grief care is much more complex than this, but just those basic, when you take Psych 101 and they tell you the 5 stages of grief that are like denial, anger, bargaining, depression, and acceptance. Those are the things that I see, and you don't have to go in a straight line. You can bounce all around. Those are the things that I see happening when people are calling. So it really to acknowledge, first of all, that for very many people and for their partners and maybe even for other members of their family, it is a real mourning process. They're either grieving the birth that they wanted to have. It could have been a birth that they've been dreaming of since, forever, or they're grieving in some other way. Many people are blaming themselves. That's part of this the bargaining thing is they'll do, oh God, if I had only known, I would have been doing spinning babies since 28 weeks. Now that I'm on their website, I know that would have been good. I would have seen a chiropractor since day one. I would have done this, done that. And the first thing I like to do is really tell them it's not their fault. None of this is anything that they should have known to do. The fault lies with us, with prenatal care providers, and with our system that's not integrated. So we're not having OBs necessarily know about biomechanics. It's not necessarily that they don't believe that it would work or whatever, or that they don't care. It's just that we aren't educating. So they don't know that they need to be maybe sending people to body workers much earlier, focusing on prevention, letting their clients know earlier on if they suspect that the baby's breech, because there is stuff that can be done by other providers before the stuff that they can do, which is the ECV and
but that requires collaborative care, but we don't work in collaborative care. So that's really the problem. I love how you highlight that.
Yes, it does. And there is, there's some places that do work in collaborative care. I've got OBs in my area who I can call up and talk to. There's many doulas and chiropractors in
but you've established those connections. Yeah. In the system, the United States healthcare system. Right. Yeah.
So broken.
There's no collaboration. Yeah.
So I first try to address the emotional component of this. Sometimes people call me and they're like, I don't want to talk about my feelings. I just want to know what to do. And then that's fine. I just give them some tips. But I try and kind of bring them back, because earlier in my career, I had some regrets where I didn't really focus on the decision-making process and helping them make informed decisions as to the extent that I thought it was really necessary to. And I got a couple phone calls, years later being like, I feel like I didn't know about this. I didn't know that this was an option. And I was like, I told you that vaginal breech, if you wanted to travel, was an option, or I told you that a gentle cesarean, if you wanted to go to a different hospital, was an option. But they weren't in the right headspace at that time, because they were in a place of grief, and you don't recall information or retain information. You retain a small fraction of the information. So I've really changed kind of how I help them process and how I provide the information. We also talked a little bit about sympathetic overload, which we don't have time right now to go into the neurology of chiropractic and how phenomenal that is. But I do find that most of my clients, when they call me, are in this sympathetic overload state, which most people have heard of fight or flight or freeze. There's another part that researchers have been studying called fawning, another F, fawning. And this is a tendency to kind of give into authority or perceived authority figures. So you kind of fawn over somebody who may or may not actually be worthy of that behavior, and say yes to things that you may not say yes to typically. And then later on,
yeah, it's a coping mechanism, just like flight or fight. Yeah, it's not really conscious. It's an autonomic response.
Right.
I love that you bring this up. It's a big part of my awareness too. It's brilliant. So
So
when someone is fawning, oftentimes, just to point this out a little more, because it's kind of a new concept for some people.
Right.
They are saying, oh yes, okay, thank you, doctor. Okay, scheduled on Tuesday. Okay, that's thank you so much for discovering this. I'm so glad. And then they leave and they're like, wait a second, did I just agree to a C-section? What? Wait, what?
Yeah. or what's actually even scarier, Augustine, is when they do that, but they don't do the processing. Did I just agree to a C-section until after the C-section?
Right.
Grief processing takes a really long time.
Right.
And
Right.
in trauma, and we know now that, you know, trauma is usually not processed when you're experiencing the trauma. It's more about just acknowledging that you're going through the trauma then, so you know that something's going on and you need to get your support system together for when you're ready to process the trauma. So yeah, so that's the first thing that I do. And then this next thing that I do is I usually walk them through the entire spectrum of their options. And this is from an advocacy standpoint. As a chiropractor, I can certainly also advocate for my clients, but this is more of a doula advocacy position. So we go through all of the options, and they're different depending on where you are. So it's important to find a consultant who's local for you. So we go through everything from their right to an unassisted birth, which is not necessarily something that I agree with at all, but I just go through all of their options, all the way over to a planned scheduled cesarean and the different types of cesareans they can plan, what the different providers that we have in the area along that whole spectrum. And in the middle, there's things like a trial before cesarean, which a lot of people have never even heard that could even be something that they could do. And all of the other things in between, so that I know that from the beginning, I've done my due diligence, that they are aware of the full spectrum of options. And I just kind of breeze through those very quickly and then ask them, right now, what are the things that you're the most interested in? And they say, oh, I know I never would do a vaginal breech. I don't care if it's at the best hospital in the country, I don't want to do a vaginal breech. I want to do everything I want to right now to get the baby to turn on my own. And then a week from now, I want to do an ECV if that doesn't work. So then we focus in on those things. And we also talk about how a lot of people with breech babies, once they start the information gathering process, will change their mind several times. That's fine too. That's part of the process. So we kind of have a plan A, plan B, plan C. It's like the choose your own, those old books where you chose your own mystery. You know?
Yeah, that's great.
If X, turn to page, you know. So those
That's great.
where I start out.
Well, Caitlin, can I ask you to just sort of clarify a little bit, and jump in here anytime, and certainly, you know, as a healthcare provider, I could as well, but I'm enjoying interviewing you both, so I'm going to ask the questions. So I love the way that you help us understand that grief is a part of this. But for those that are really, this is so new to them, what are they grieving? Like, help us understand why this changes birth so much.
There's so much that they're grieving. The biggest thing is really the loss of the birth that they were planning. So even if they were planning a medicated birth or an induction or whatever, they were still planning a vaginal birth. Like very few people plan a cesarean. Just especially first, you know, it's very rare for somebody to just be like,
and not very many people opt for abdominal surgery.
Right.
Yeah, unindicated. Right. Yeah.
So the biggest thing is really this loss of this dream birth. And you know, many people I work with are planning, their goal is to have an unmedicated birth. So they're also losing that. They might have been watching, you know, documentaries and listening to their friends and reading Ina May Gaskin books and doing all this stuff, and they have read all these birth stories that they're dreaming about, and then all of a sudden they're being told that it's not an option to have a vaginal birth. It always is. It might involve travel or various other things, but they're being told that there's no way. Usually they're just said, okay, we may or may not do a ECV if you want one, and then we'll schedule your cesarean. So they're also
that's very clear. That makes it a lot more clear. Yeah, and go ahead. What you were going to say? Something else?
And they're also grieving the loss of power. Yeah. So if you walk in and somebody says to you, your baby's heads up, so let's schedule a cesarean. They don't give you any, and then often I'll hear back that the birthing person will say, don't I have any options other than the ECV? And they say, oh, you can try acupuncture, or you can try these things, do some.
And that's in California. I'm just going to say that's in California.
Yeah.
In Alabama, they're probably not saying you can try acupuncture. You know, like.
Well, there's some amazing doulas in Alabama, so I'm sure
that's true. But the OB probably isn't saying that. You know,
I don't know because I don't work in Alabama, but So
And
yes,
that's
and
just
it's not,
an example.
yes.
Not bashing on Alabama.
We're gonna get, there really are great
Yeah.
schools in Alabama. Anyway, so but even here, there's such a big, there's a huge discrepancy in what they're being told in terms of options. So they're often are not being told all of their options. Hardly ever do I have anybody who's planning a hospital birth come in and say, hey, I heard that there's a great OB in different parts of the state that I could go. My OB told me that. They don't say that. They say,
Yeah.
you have
size fits all.
ECV, cesarean. That's your option.
Right.
So
Well,
they're,
so let's
they're being taken that power away from them, and that's part of what they're grieving as well.
Yeah, and that is such an important point. And I want to actually pause the breach conversation if we can to talk about this little highlighted problem in the maternity care in the United States, because you two function outside the system. And so because of that, you have a really great vision of the whole, as opposed to those that are very in the system and can only see, you can't see the forest for the trees. They're very in it. You both have a very broad perspective. And this is a really pervasive problem in the US of not getting true informed decision making, true informed counsel around options. And so first of all, I see you both shaking your heads, which means I see that you also see this problem. And I wonder, like, for those that are encountering this or don't even know they're encountering this, what's like in this pause moment on all issues where we might not be getting full story, what recommendations do you have for pregnant people in searching for options?
First of all, you don't have to go along with everybody's first recommendation. There's the whole thing about what you're allowed to do inside certain systems, and you don't have to stay inside the system you're at, and you can look for alternatives even if your provider is not providing it to you. Some very restrictive systems in my area, if you just ask a question, they roll over completely. They say, this is how it is. And then you go, well, can't I do that? And they're like, oh yeah, you can do that. So
that's so interesting.
Research it themselves sometimes.
My co-host Keisha Chiapinelli says all the time, her favorite quote is, the squeaky wheel gets the grease, the squeaky wheel. So she's like, so be a squeaky wheel. The more you ask, the more you talk, the more you're like, but someone's going to pay attention. And this is what you're saying too.
Yeah. What are my other options?
Yeah.
It never hurts to ask. And you can ask different providers inside the same system, because oftentimes they're seeing different people on different days.
Yeah.
And I also, if you have, because a lot of people who just found out their baby is breech are under a big time crunch. They really don't have a lot of time to do a lot of research. Yeah. So finding a consultant like Anna and I do that work. There's a lot of doulas who specialize in working with people who have breech or twins or VBAC or know things that they might not be provided all their options, to reach out to those people in the community, because we can help streamline. Right now, I know a lot of us are doing during COVID, and with people who don't have regular paychecks, are doing pay what you can or pay later. So there's really no reason right now to reach out. There's some great resources online for learning about your rights. One of them that's absolutely phenomenal is the Birth Monopoly website. There's a class on there it's literally called Know Your Rights. So you can take that. It goes through the
We'll
legal
link
rights.
that in the show notes. Thanks for that.
Yeah, and there's the Coalition for Breech Birth Facebook page. So if you're someplace where you don't even know, where to start finding somebody who can consult with you on advocacy, you could go on there, and you need to answer a few questions, and then you could write, I'm looking for somebody who knows about options in Detroit. Is there anybody on here who can help me out? So there are things that you can do to be educated. But in California, we do find that ultimately most places will support the patient's rights. If, just like Anne said, if they aren't doing it and you question them about it, then sometimes they're like, oh yeah, well now we can do it. So it's an off policy thing for their hospital. So to go off policy, they have some liability attached to it, and they need to be told, I'm not going to do that. So we're going to have to come up with something else. And then they're like, oh, okay, in that case. So that's
right.
just, yeah.
That's a very interesting distinction. Well, thank you for those tidbits. I appreciate both of you. You're such advocates in your communities, and we are, all of us, involved in helping to grow advocates all over the country. So thank you for that. Okay, so somebody has found out that they have a breech position baby at the end of their pregnancy. They have made a frantic call or a frantic Google, Facebook search for like, how can I get resources? They've found someone who's like, you don't have to just have a scheduled cesarean. You can, there are other options. And they go, okay, what, where, when, how what is this? Walk us through the steps. And I know this conversation, like when I talk with my, community-based clients, this is always, it's such a time crunch because we find out at 35, 36, 37, 38, you're already in the due window. Like you could go into labor any moment. And some of them don't find out until the week before they're due or their due date, right?
40 plus 5. Yeah.
Yeah, right. Or past 30 days. There's like, you literally have maybe an hour to make a decision, maybe a day to make a decision. If you're really lucky, you have a week to make your decision. And that's an extreme amount of stress and research. So let's break it down in case someone is searching for this info. What are the options? And let's talk from least rigmarole and wild experience to the most. So first of all, I found out my baby's breech. I have more than an hour. What can I do?
I do love spinning babies. They
Absolutely.
have
Okay. Yes.
It is a very
So
helpful.
this is my first recommendation too. Go to Spinning Babies. So both of you happen to be Spinning Babies providers, educators, and tell us, what is the website? What do they look for? Like literally, what do they hit in the search bar? How do they get to the info that you're talking about?
So I'm going to default to Anne for this because I am a Spinning Babies trained body worker, and
Okay.
That's staying tracked. And also I have a lot of training on working one-on-one with clients. Anne is actually also, she's got all that, and she's a Spinning Babies parent educator. So she works with clients, and they're doing some really exciting things online now. But that's the first thing that I have people do. Sometimes their babies turn before they even come in for the appointment. And I'm like, you should still come in though, because you still need chiropractic. So you want to go over some of those, like the
and tell us like, what do they do? Like, I want to be really nuts and bolts. Like they go on to spinningbabies.com.
There's a whole bunch of stuff you can read about, but if you want to make it really simple, click on the shop button and go to the ebook, which is about Breech. I'd have to look it up.
I think it's just called the Breech book.
It's the Breech book, yeah. Well, there's one that's a flip thing about breech births, but then there's a downloadable book for parents. It is $10. It's $9.95. It's like nothing. They could charge so much more. It's very easy to read. It goes over the activities really well that parents would use at home, and it goes over a plan on how to use those over the course of how much time do you have? How much time do you have? Do it like this. You have less time? Do it like that. You can't do that? Do this. It's just very, very friendly to parents. And you can do this. You can do this stuff at home. The devil's in the details a little bit. I tell parents, done badly, these activities are very helpful. Done correctly, they're magical.
Wow.
So
wow,
I love
that's
to go
awesome.
over them with parents if I at all can. Knowing that in the US, the Department of Homeland Security has said that chiropractors are essential. So most states still have chiropractors practicing, and most of our perinatal chiropractors are still in practice, even if it's not as many days as normal. Now, the question is, are people comfortable coming to us? The people I talk to, and in my office, we are instituting extreme hygiene, and I'm finding patients are coming to me telling me that I am the only place they're going to outside their home. They're not, late pregnancy, they're not going shopping. They're hardly going to the OB. It's all on the phone almost, but they're coming to me.
Yeah.
So that makes
and it's really it's awesome, and it actually makes a lot of sense. It's not actually a whim or like frivolous. It is essential, because we all know that the more time you spend in a hospital and the more interventions you get in a hospital, the more at risk you are for everything. So decreasing hospitalizations, decreasing cesareans actually saves lives. And we know this on every level of policy and government and research and et cetera, et cetera. So helping the body, the baby, choose a head down position absolutely actually saves lives. So we'll talk about actual breech birth in a little bit, but from the top down, that is the smartest thing you can do. So I love to hear that people are doing that even now in this crazy time. And I love to hear that chiropractors are essential and that is offered. So that's fantastic. So the Spinning Babies website, lots of info there. The Breech book for parents, lots of info there. That'll give you a good guidebook for how to start. And then I'm going to ring the bell for chiropractic.
Yeah.
That's why I have you both here, because I've seen it absolutely do miracles over the 20 years I practiced seeing patients. Many breaches over the years have been resolved with that amazing bodywork care. So if they can see a chiropractor, that is one of the first steps. Will you tell us what you do when they come to see you? What could someone expect if they've never seen a chiropractor? What are you doing?
Can I just jump in real quickly first
Yeah.
to say,
Caitlin, go for it.
When you're looking for a chiropractor, not all chiropractors work with people with breech babies, and not all chiropractors are trained in that. Just like I'm not someone you want to see if you were in a car accident. That's not my specialty. So personal injury, and even just like basic pain relief is not my specialty. So, but birth biomechanics is my specialty. And there's ways that you can find people who are specifically trained in that. The absolute basic training, in my opinion, and I'd love to hear what Anne thinks about this too, would be the ICPA certification for Webster. That is the absolute and I'm not talking about like, that's the minimum training in prenatal that anybody seeking a prenatal chiropractor the chiropractor should at least have that, and hopefully way more than that. Those of us who specialize in this, like Anne and myself, we are at so many trainings. We go to many
thousands of hours of continuing it.
Yeah, but we go to trainings that other chiropractors wouldn't go to. Like we go to like midwifery trainings and anything that has to do with birth biomechanics we go to. So it's important to kind of know what you're looking for. On the ICPA website, that's where you can go to search for somebody in your area. It's ICPA4kids.com. And there's a doctor search, and you can search by zip code and find out what their certifications are. And you're looking for, again, minimum of a Webster certification.
That's awesome. And we'll put that link on the show notes as well. But I just had this thought, like, because chiropractics are so special, have such specialties, we don't hear about that often. They kind of get lumped into one thing.
Right. And all that said that I just said, if you're someplace where there's no chiropractors with Webster certification, that's not, you might have to drive a little while, but we're everywhere now. But if you happen to be someplace that doesn't have any, going to any chiropractor is better than not.
Could be helpful. Yeah, right. You just want to find the one that's the most helpful. But I want to make a point here. Caitlin, I kind of think you've pioneered this new term, birth biomechanic, birth biomechanism. And Anne's agreeing. I heard this first a couple years ago out of your mouth, and it's been like ringing around in my head. Because I, as a midwife, I also am deeply invested in understanding the mechanism of birth, how baby and mom's soft and bony tissues work together to complete this process. And so the word makes a lot of sense to me. Will you define it for us, like what you have coined here? Because I think it's actually pioneering an entirely new collaboration and specialty that we don't have anywhere else.
Yeah, and that's why I think it's so important, because it's an interprofessional term. So you don't have to be a chiropractor to be someone who is very well trained in birth biomechanics. You can be a massage therapist. You could be an osteopath, you could be a midwife. Some of my greatest biomechanical teachers, like you, for example, Gail Kelly, Nicole Morales. I mean, I could keep naming lots of people. They're midwives. They are Julie Tilsner. They're not chiropractors. So just because you might be in one certain discipline or profession, I should say, doesn't mean that you're the expert and that you don't have a lot of things to learn from other people in other professions that you can then fold in. So for example, Anne and I do a lot more soft tissue work than your maybe typical chiropractor. We do things that we've learned from midwives. We do lots of spinning baby stuff. So it's basically somebody who focuses on the structures, the biomechanical structures, so fascia, ligaments, the muscles, bones, all of the things, and then the nervous system component behind that as well. But all the things that might influence the balance of the uterus. So we're not actually working on the uterus, we're working on things that are kind of all around it, and they might influence the torsion of the uterus, and then that might possibly influence the position the baby takes. So one of the really cool things from all this is that, and I want to point out that there's no evidence to support this. This is all anecdotal, but Anne and I know from our forums that we all know that this happens, that the same factors that the imbalances that tend to cause a baby to maybe decide to go breech, and of course we never know for sure, but those same factors also cause other positional, or also may provide a biomechanical tendency for the baby to choose other positions that could be difficult for labor. So if the baby turns after one adjustment, it's still really important to continue chiropractic care to prevent things like biomechanical influences that might cause the baby to maybe tend to be posterior, which is a huge babies who are posterior. And I don't want to go into like all the specifics because we could talk all for the next hour.
Yeah.
But there's more. What I'm saying is there's more benefits for the birth for after the baby turns.
Yeah, no, I love this point you're making, and Anne's nodding her head. She, I think, agrees too, that this, that breech positioning can actually be a gift in a way, because it's like a red flag, a yellow flag that raises like, hey, things are not as they seem. And because you and others and many of us in this newly developing kind of intercollaboration, understanding things that have previously not really been understood, are trying to pioneer a support system, a mechanism in collaboration in our systems level care, whereby people who discover this yellow flag can have consistent and long-term success and attention to changing the birth biomechanical issues that are present. And breech is one of those, like, hey, pay attention, something's not right. Yeah.
Right. Talk to patients about the fact that breech is a symptom of the problem. It's not necessarily the problem, right?
Yeah.
And yes, I want your baby to go head down. I'm not going to make your baby go head down. I'm going to add balance to your body so that maybe with this ease, this balance, this room that they should have had all along, they can make that choice that's more advantageous and less stressful to everyone. But once they're head down, you can't stop. That almost indicates even more that you need to continue with this and keep balanced and have things go well. And when you don't, sometimes you have some interesting stories about how things change over time.
And I think it's also important to note that it's not just about the baby, as Anne said, it's not just about the baby turning. It's about creating balance. The goal isn't necessarily to get the baby to turn. We're not turning babies. We're creating balance so the baby can make the best choice for their particular situation. But one thing we have noticed, and again, I always like to point out because I am very much in as a doula making sure that when I'm saying something that's not based on research, that I acknowledge it. So this is not based on research, but the research that I would love to see, because anecdotally we see so much of it, is the babies, I believe, are more likely to turn during an ECV, significantly more likely. This is my theory and many other chiropractors' theories, if they've been having regular body work. So during the last 2 to 3 weeks, chiropractic or other kinds of body work. And that's something I think a lot of people, they think it's like a either or, like, am I gonna focus on trying to get my baby to turn on their own, or am I gonna do an ECV? We can all work together. There's benefits if you're making that choice as well.
As a provider who does do ECV myself, it's absolutely one of my requirements. I mean, it's one of the reasons I've had consistently an 84-85% ECV success rate, is because I require body work before I will do it, because there's just like all the things that can make it successful. Like, we should do that. And also, like Caitlin has noticed, that the spinning baby stuff, that turns a lot of babies, right? Then the chiropractic, that turns a lot of babies. So actually I have to do less ECV because the babies are responding to less invasive techniques. So going back to that question we had about like along the spectrum. So we could read on spinning babies, we could download that book, we could find a chiropractor, especially one who focuses in the perinatal period. We could go to that chiropractor and they would do what? They would, what kind of hands-on things do you, someone who's not familiar with chiropractic at all, and tell us, like, when they come into your office, what do they do? What do you do to them?
I'm going to look at what's happening as far as the balance in their body and their pelvis, at the muscles and ligaments that are surrounding this area, but even further afield than just the pelvis, I'm going to look at how their knees and their feet are working, what's happening with their shoulders. How can I add ease to your body so that it's more relaxed all over? Less tense. How can I talk to you about activities that you do throughout your day, and a position that you sleep in, how you sit, how you get up from a chair, you know, all of these things to try to add ease. And some of them are very subtle, but can really make a huge difference. What kind of shoes are you wearing? You know, I'm trying to look at everything here.
Wow. That's so holistic. It's so thorough.
But you never know when one of these fine points might just be the thing, you know, combined with everything else.
Yeah. That's brilliant.
Yeah,
so, go for it.
So in terms of working to people who are focusing on first doing things that might encourage their baby to turn on their own, other than the things we've mentioned, postural changes, which is chiropractor can help you with. Also, there's also advice on that in spinning babies, biomechanical things that Ann just mentioned. We already talked about spinning babies. And again, I think the website's great, but getting an actual consultant, like either a doula to work with you one-on-one. We do FaceTime, like we can do it virtually. Or somebody like Ann, who's a parent educator, who can actually do a class. There's that. Acupuncture. There's I usually really encourage my clients, if they can possibly afford it, to be doing acupuncture as well. Also doing a myabdominal massage. There's another, which is ATMAT, our Vigo techniques of myabdominal massage is the certification you want to look for, the pregnancy certification. There's a homeopathic remedy called pulsatilla. There's all sorts of like folk remedy, old that we don't have research on, but there's all sorts of things that you can try doing, flips in the swimming pool. So I go through all of those with clients, and I tell them that they're going to feel really overwhelmed after I go through all these things. And then we talk about decision making. So what some people want to just do everything, like they want to take a week and do everything, absolutely everything, and spend all the money and do all the stuff and just do everything. Some people, it's way too overwhelming and they need to stop. And I learned from you actually kind of some of the languaging about that. Like, is this helpful? Does this create peace in your life? So we talk about how sometimes trying to get your baby to turn can turn into basically like a full-time job. And it can be sometimes more stressful. is stress. I believe, again, don't have a lot of research on this, but we know that when stressful events happen, like right now, we are seeing a breech wave, we call them. And during the California fires, we saw one. We've seen them during period. This is anecdotal. It's all of us on professionals on forums and at conferences saying, hey, have you had a lot more? But I would love to see actual research on that. So we go over how to narrow down what they want to do, what's sounding good for them, what's their budget, what's their time frame like, what do they want to do, so that the actual stress of trying to get the baby to turn doesn't keep the baby from turning.
Right. Oh my gosh, that's a brilliant connection. I mean, it's not funny, it's sad, but
and then the next thing would be, because of the time crunch, the next thing would be to talk about ECV. And to get this is from a doula standpoint, advocate standpoint, there's a very good comprehensive article on the evidence-based birth website on ECV. There's an amazing, this is only for professionals, but there's an amazing, I mean, everybody else can get it too. If you're planning a VBAC, on the VBACFacts.com website, for professionals, you need a professional membership, but there's a fantastic, totally research-based lecture on breech and VBAC. So that combination, but even if you're not a VBAC, which is a vaginal birth after cesarean, that information is great too. So we kind of get a plan in place. What's your time frame like, with the understanding that if things start getting too overwhelming, it's okay to just say, screw it, I'm just going to stop everything right now and then go forward. I do encourage people to start researching and deciding whether or not they want to have an ECV or 2 ECVs or 3. Some people really don't realize you can have more than one, before, like, right away. Because sometimes people will think, earlier in my career, I had a lot of people who would say, oh, I just really want to do all this, and I'll deal with the ECV at 37 weeks because that's the earliest I can have it, or my doctor won't do one before 38 weeks, so I'm just going to get my baby to turn and I don't want to think about the ECV. And then it's time, then sometimes the baby doesn't turn and they're stuck with this big decision. And that's the same goes for if the baby still doesn't turn, deciding about what kind of option they want to do, from vaginal breech to a planned cesarean, and all the possibilities in between. So I do encourage people, and I've flip-flopped about this over the years, but I've just learned that even though it is overwhelming to get all the options at first, it takes some people time to have that processing on the back burner. So the time to talk about it is not when they're scheduling the cesarean.
Right.
One of the things, and then just lastly, this is when that whole experience of the grief process also comes into, and the biggest thing with that I find is this denial, which is fed into a lot sometimes by their providers, that because what the provider solution is, their solutions are, like a medical solution would be ECV, then cesarean. So it's this denial that there's nothing else they can do. And the baby will probably turn, Most babies turn with ECVs. Don't worry about it. You don't need to do anything else. Just calm down until the ECV, and then we'll deal with it after that. That's not enough time to process if you want major abdominal surgery. Like it's really not, from a psychological standpoint, for most people. So, so that's a little bit about
That's brilliant. That's brilliant. Well, let's take this moment to drop into ECV, and because I do this, I'm going to talk about this, but I invite either of you to ask questions if I'm not clear. So ECV stands for external cephalic version, and it's describing exactly what happens from the outside of your body, external. A provider helps to take the head, the cephalic part of the baby, and convert it or invert it from up to down. So external cephalic version is, if it could be boiled down in a mechanism, it's essentially a massage. The degree of pressure, the degree of force that's used is very varied depending on the provider and the location, but it's massaging the baby inside the womb from the outside of your belly, from head up to head down. And various providers have various comfortability with offering this. Some don't offer it at all. Some will offer it very hesitantly. Some will offer it if only certain conditions are met, like the mom is numb with an epidural and in an OR under ultrasound guidance. And some will enthusiastically offer this option with lots of evidence-based care in lots of locations without any need for extra accoutrement. So researching ECV in your area is an added stress because it's not the same. It's not apples to apples. You have to know, actually, not only are there providers that offer it, but what method do they use? So I'm not an obstetrician, so I cannot speak to the obstetric method specifically. But again, like Caitlin helps us use the language, very anecdotally from the outside, all of us who have worked with people who are seeing obstetricians for this process have seen varying degrees of success, have seen varying degrees of comfort for the person who has the baby in their uterus, and have seen varying degrees of the kind of language that's used around this technique, from being very encouraging to being very fear-mongering. And so it's really not a one-size-fits-all. You have to know who in your community offers this and what method they offer. So I always recommend, if you are in the situation, you start talking to your provider or you start researching a provider somewhere that would do this for you. It's important to ask, where would you perform the external cephalic version? And if the answer is in an OR, you get a very different picture of what procedure is about to happen than if the answer is, I can come to your house, right? The next question that I would encourage is, what is your success rate? Now, the challenge with this is that it's not easy to verify.
Yes.
There's no real records kept of this except for that provider themselves. And we don't totally know if that's tracked well or truthful or what have you. So it's a tricky one. But on the whole, we're going to believe that providers are truthful and honest. And on the whole, there's kind of a range. So if they're saying that they have a 50% success rate, that's quite different than what we would expect to be more normal, which is about the 70 to 80% success rate, right? Do either of you know of providers in your area that are quoting a higher success rate than that?
There's one in my area that if I've been working with that person for more than 2-3-ish weeks, we've had almost 100% success together. Wow. And I would reiterate that I believe that it's the skill of the provider that's the number one factor in a successful ECV. I don't like saying successful ECV and an ECV that ends up with the turn of the baby, because occasionally there are, occasionally there are some things that are not biomechanical that are reasons that the baby is there, and then the baby not turning in those situations is successful because the baby knew what the baby was doing. Yeah.
That's right.
So you can, again, the best thing to do is to reach out to doulas and to consultants who we spend a lot of time going to ECV and going to ECVs, talking to people who've had ECVs on forums with people concerned about ECVs in your local community. So most of us can, and chiropractors for sure, because most of us can give some suggestions about who
actual specific people, right? Because you hear about them.
People. Yeah, exactly.
Yeah.
And I would add to just having, I do always suggest that you have a doula go with you to the ECV. Right now with shelter in place, that's going to be on your phone, but that's okay too. And there's many things you can do that we can talk to you about to maximize your odds of the ECV resulting in the baby turning. So there's many things, and there's also many choices that people have about ECV that they don't realize that they have. Provider is just one of them. You can go to a different hospital. You don't have to have the provider you've been working with do the ECV. You can go to somebody else for the ECV and then go back to your provider after the baby returns. That's fine.
Yeah, I've had a number of clients that are not my clients, did not want a home birth or a birth center birth. We're not interested in that, but we're very interested in a more gentle approach to ECV. And so I've done a number of opportunities to turn babies that I didn't actually ever end up delivering. And so I always recommend that. Like, if your provider is saying, no, I won't do that, or if your provider is saying, I'll only do that with an epidural in place in the OR, and that's not something you're comfortable with, I always recommend maybe looking for some community-based providers if you don't want to or can't find any hospital-based providers that will help you. And then, as you were saying, like in preparation for it, certainly body work and all the spinning babies and all the things we've been talking about. But one thing that I have noticed over the years that makes a profound difference is inversion. So the mom's body actually gets non-gravity oriented. So basically your bum is in the air. And when you do knee chest is what we call it, it's fairly uncomfortable, but mom is on her knees and then she lowers herself all the way down to her chest, not just hands, not just elbows, but even all the way down to her chest. Then we stay like that for kind of as long as we can, sometimes 10, 15 minutes, sometimes an hour. And it's kind of as long as mom can handle it. And if it's a very short amount of time, she kind of goes down to her side and then we'll get back up again a couple of times to be gravity neutral and then gravity negative, so that we really can give the baby the best chance possible to pull out of the pelvis. Because the higher the baby is in her body, the more likely there's room for this baby to move. So to me, that has been one of the most powerful and empowering personal things that a person can do without the need to research anyone else. So you just tell your OB, even if it's going to be in the OR, under epidural with ultrasound guidance, you say, before we do anything, I'm going to spend half an hour on my knees, and you just are going to wait. Like, that's something you can do. And
Right.
that has a high chance of creating success. Is this something you guys recommend?
Yeah, actually, I always, because I try to attend, as I said, ECVs with my clients. I've always done the basic spinning baby stuff before an ECV. After I took one of your classes, I was doing open knee chest, and more than just open knee chest, I was doing, it's just hilarious to me that they get to the hospital and that they're trying to get the baby to turn, and what they do for the hour and a half before that is have them lay in a reclined position while they're doing all the stuff. Yeah. And, it's like, it doesn't make sense. So I've been either doing, I actually learned from a nurse who assists a lot of ECVs, that she does the bed in the opposite, or has them turn around.
Trendelenburg. Yeah.
Trendelenburg. Mm-hmm. I was trying to not use technical terms.
Oh yeah, sorry.
But you can
tilted bed. Yeah.
And so and then I also, but after I took your class, there was one time you said ideally 45 minutes. So I actually have been doing 45 minutes of open knee chest with and to prevent the back pain from that, I just have partner hold there's a great pitch. Yeah, hold and then something. We just use a sheet at the hospital, but Manteca or Rebozo or whatever you want. There's a good picture of that on the Spinning Babies site if you search open knee chest. Yeah. So doing that before, reducing anxiety. So again, being very well prepared for it. You're describing it. I've seen videos of you doing ECV and your skills are just magical, but most ECVs I've been to do not look or feel like a massage. Most hospital ECVs, some of them honestly look to me like surgery from the outside. Like they're really aggressive, but the baby turns, and it's way better than getting a cesarean for most people. That's what most people think.
But they feel
being prepared, watching lots of watching YouTube videos on it, having support there, talking about what it's going to be like. It's also very important to understand your options in terms of there's a few drug options, medication options for ECV. Some are based on research, some like fentanyl are not. And the under spinal is, but the research isn't, it's very slight increase. So that article I mentioned on the evidence-based birth research on, if you just go into Google, evidence-based birth research on breech version, it'll pop up. And that goes over some of the things that can influence the turn rate with an ECV.
Wow. Thank you for that. Anne, you were going to add something. Go ahead.
I'm really excited to hear what you guys are saying about the inversion prior, because that is not happening around here. I do tell them to do the spinning babies activities and do the side. I say, be in there doing the sideline release while you're waiting for them to come into your room.
Yeah.
But,
yeah. And I do need to say this just because I have one of my teachers, Nicole, actually in the back of my head saying, there are times where the baby's head is actually stuck under the ribs.
Right.
Not the bum stuck. So from a biomechanical standpoint, it's really important that you have a provider evaluate. Hopefully, like a couple of the OBs that I work with in Santa Cruz, they know they understand biomechanics enough that they can say, oh, this baby is right here, this bottom's right here, this head's right here. So if the baby happens to be one of those babies where the restriction is actually at the top, and this is something that's not addressed by a lot of body workers. A lot of body workers are working mostly on lower uterine segment, on the structures around that, thinking that we're trying to get the baby to come up so the baby can turn. But sometimes baby is, I hate using the word stuck too, but is the restriction is actually at the respiratory diaphragm, which is higher up. You can't see what I'm doing, but it's higher up above the uterus. So having somebody evaluate for that before you do, just for that one, I just want to say that one caveat about doing the inversions.
No, it's so smart. Yeah. It's so smart. And it's a really good reminder for the providers who are listening that it's never a one size fits all, but I think the proportion is so different, right? Like we're talking the vast majority of babies are really need to come up. But just like, you know, like I teach about asynclitism, right? So asynclitism is the same thing. The vast majority of asynclitic babies are anterior asynclitics, but some of them are posterior. And we use a totally different skill set to solve that. So that's a great reminder. Thank you, Caitlin. So once they have found a ECV provider, and they have worked on their emotions and getting ready for this, and they've seen providers that or done the spinning babies worksheets or been inverted for a time, they're ready. They go in for this procedure. You guys have seen it from the outside. Caitlin, you're saying it's really rough for some people. Yeah. So like, how does somebody deal with it? Like you've been in many of these. Like, I know how I tell my mamas to be ready, but what do you guys recommend?
Anne, do you want to?
Honestly, in Southern California, it's so difficult. There are a lot of different health organizations. I can't keep track of all the different providers, and sometimes they're going to a group and I don't have great choices for them. I'm trying to develop more choices, but I don't have great things to tell them at this point. And you guys telling me that a 50% success rate isn't great, I'm like, that's pretty good for around here. If I had
that's less than the research average. That's in Southern California, you're under the whoa.
I think so. I
have a couple. There's a couple people I can, if they're willing to drive. There's some people I might have names for, but anyway, we'll talk about that later.
I tend to find that people feel pretty beat up after the whole thing. It's not a kind procedure, and I did have somebody great who was, you know, a mile away from me. He retired. You know?
Yeah, it seems to be the older providers tend to be more gentle, I think. I don't know what happened in the 70s and 80s that made this an aggressive procedure, but midwives around the globe have had this procedure as part of their skill set. In fact, midwives are undoubtedly the ones that showed obstetricians how to do this 100 plus years ago. Sure. And the midwives that I know and trained with and practice with, my colleagues, do not describe this as an aggressive procedure. And so again, I'm just going to ring the bell that there are so many levels of this care. In my years, 20 years of doing ECVs, I warn my clients by saying, this should not hurt. If this hurts, we stop. Yeah. So we're going to work together. And I'm going to need your feedback every step of the way. I'm also going to be asking for your baby's feedback. And together, we're going to work on helping your baby find the way down. And honestly, if it hurts, I stop. And even with that, I still have a very high success rate. And I think that this is because we come at it with a really different perspective.
Yeah.
And I think maybe ECV, to go off into kind of a philosophical perspective, ECV might be one of the greatest kind of bellwethers showing the difference in care models, because this sort of method of power over and I know the way, let me turn your baby, is very obstetric method, versus the let's work together, power with, this is a massage that shouldn't hurt, is very much more midwifery. Now, certainly there are many people who cannot see midwives, should not see midwives. Their risk status or their situation in life or whatever means that they do need high-risk obstetricians. And so this is not to say that vilify one or the other, but it does point out a basic philosophy of care difference that I think is notable. If the pregnant person is going to receive an ECV with an obstetrician, Caitlin, one of the things that I love about you is your research focus. And I know that I've heard you quote it before, and I've read this too, that actually an ECV with epidural or spinal guidance or spinal medication that makes the person numb is evidence-based.
Well, there's a slight, and again, when we talk about research, like I don't like saying that I'm just going to refer back to that evidence-based birth article, because then you can see the actual numbers. So there is a slight, the research does show that there's a slight, and slight is a weird, that's just my term. Like for you could look at those numbers and you might not think that that's slight, increase in the baby turning with spinal. It's not a big one, and I don't have it memorized, the actual stat right now, but we can bring that up. But I do want to, I think what you pointed out about there being three, I talk about this with my clients as well, there's three people that are involved in this turn, directly involved in the turn. I mean, obviously there's energy from your family and your doula and everything, but there's three people who are active participants in the turn, and that's the provider, the OB or the midwife or whoever, and the OB or the midwife. And then there's the, or it could be a family medicine doctor too. And then there is the baby. So a lot of people forget about the baby, that the baby is part of this turn. And then there's the birthing or the pregnant person. So the pregnant person communicating with the baby, just like if the baby was already out, baby's pretty, usually this is happening in 37, 38 weeks. The baby's got neurologic development at that point. So you're already communicating with your baby. And so telling your baby, visualizing, doing all these things during the ECV, trusting your provider, finding a provider you trust so that the three of you are working together to turn the baby. And one of the things that's been so to go back to this, why is there this possibility that there might be a slight increase in turn rates with epidural? My theory is that the OBs are less intimidated. Yeah. So that they're worried about hurting people. They maybe have different techniques that you use. And that's why I see fentanyl being pushed at more and more hospitals now. We have zero research. If there is any, and anybody watching this knows it, I'd love to see it. We have zero research showing that fentanyl helps. In fact, an ACV turn, it might, make people feel more comfortable, but we shouldn't be telling them that it helps a turn if it doesn't. And it's putting, when you take these three people and you put two of them on an opioid, the likelihood that everyone's going to be able to work together to get that to happen. So there hasn't been a lot of conversation about that concerns me. And there certainly are many things that you can do to kind of, and then at the same time, there's a lot of people who, the stress of and the anxiety from getting an ECV, they would prefer to get fentanyl, and I completely support that as well. It's just that I want them to know that that's not research based. So
yeah, I would agree, and it's the same with the epidural. Like getting an epidural placed is not without risk. That also has risk and repercussion. And about 3% of the time it doesn't work, and about we have this other small percentage of fluid leak and headaches, and like it's not without risk. But if is something that feels like it's going to help you bring peace and relaxation around this choice you've made, then I'm totally for it. And I think that will be a part of the decision-making process. But I love that you pointed out, like, putting 2 of the 3 people on opioids doesn't generally create good working relationships. We see that in the workplace. We also see that in obstetrics. Like, opiates are generally not the answer. But if that is what brings you peace, if the idea of relaxing completely into the hands of the provider makes you feel more relaxed, I agree. I think that is a choice that should be on the table. However, the vast majority of our listeners feel differently, and feel like actually they would like to be an active and conscious participant in the process that deeply involves the very core of their body. And that the risks to the baby of narcotics on board, opioids on board, are also something they want to avoid. And so the point that you made that I really want to drive home, that to me is maybe the most important part of this whole process, is that you trust your provider, that you have a connection in such a way that you're like, we can do this vulnerable, scary thing together. And I will let you put your hands deeply into the center of my body. Like, that's what makes it successful, I think.
Yeah.
I mean, certainly the provider has to have skill. We have to know what we're touching. We have to know how we're touching. But more than that, it's the relationship development. And on the whole, I think that's why, there's all this, debate in various circles about why midwives should be allowed to do ECV, which makes me giggle. But aside from who gives who permission, I think this is why we're perhaps so successful with such a gentle touch, is that actually forcing it is not necessary when all parties are involved actively. But that's just me.
Not rush it. Yeah.
Yeah. And it's a based on trust and respect. So I respect this baby's say in the process. I respect, and I know what a no feels like from a baby. I respect this person. She's not just a vessel for this baby. This person is an active, sovereign part of the process. I am touching her core. I mean, we do ECV, you're up under their ribs, you're down in their pubic bone, right above their, we are into the crook of their head. We are deeply in the center of their body.
You're pushing on psoas, which can have so many emotional responses to all sorts of stuff. Yeah. It's
so many. And if we have any history of sexual abuse or sexual assault or trauma, which, by the way, underreported, they say 1 in 5 women have, which anecdotally I would say more like 80%
in
of
my
women
practice,
do.
Yeah. Most.
So if we have a history of sexual trauma, we have the potential to activate that trauma by this touch. So, I mean, I don't know. I think even more people should have the option to numb out during this process because it might be too much. But also people should have the choice to have a conscious, clear, informed connection with a provider that they trust in this process.
Yeah. And it's a really good time to back up even and say, even though ECV is research-based, that it's safer than a cesarean, it's still okay not to have one. Like, and it's okay. It's okay to skip all this stuff. Like we talk about that, these are options. So all this spinning babies, changing your life to try and get your baby to turn, spending all this money, doing all that stuff. Some people just choose to go straight to either planning a vaginal breech birth, and if the baby turns before, then they'll just unplan that and go back to their first plan, or they plan to go directly to a planned cesarean. And there's no bad choices here. There's really not. As long as those choices are based in that they're educated choices, so that you have the actual numbers. The numbers,
and they're not pressured. They're not pressured choices. Yeah.
Yes. And that you're not bullied or coerced or emotionally manipulated into it, that you feel like you've been giving. And I'm talking about both ways. If you're planning a home birth and you feel like your home birth midwife and your super holistic doula are pressuring you into it, an ECV you don't want, or into a vaginal breech you don't want, that's just as horrific as being pressured into a cesarean you don't want. So it's first about looking at the numbers, getting true informed consent. We don't have time to go into it, but the Hermine Hayes-Klein method for informed consent is phenomenal, and that's what
she's our next guest.
Oh my gosh! Oh my gosh, I'm so excited. Okay,
That's
well,
great.
everybody watch that, and she'll go over it. And actually, in the Know Your Rights class that I recommended with Birth Monopoly, she goes into that as well. But there's a way that you should be, that providers, and as chiropractors as well, it's a struggle. It's not easy, but there's a way to go through informed consent that's respectful and that's not going to cause any emotional coercion. And we should all be trained in that. Unfortunately, there's not widespread training in trauma prevention and in informed consent, in true informed consent. So I do really want to make that point, that just because we're talking about all these options, and a lot of them are more holistic options or less intervention options, that doesn't mean that those are the right option for you. Just get the information, have it first, get the information gathering, know what your options actually are, then check in with your heart, do some mindfulness work, do whatever you need to do. If that means that you just need to forget about all this for a weekend and go and, you know, like have a romantic dinner with your partner, something to clear your head. And once you feel like you're centered, then focus on making a love-based versus a fear-based decision. This is something that the ICPA director, Janie Ohm, who was the director for years, used to talk about, and president of ICPA, that when we look at how we make decisions, if first you have a good solid research base, then the next step is to step away from that and to tap into your heart and to ask yourself, is this right for me? Am I going to feel good about this choice? And if you're doing that, if you're making an instinct love-based choice versus a fear-based choice, it's always right. No matter what the outcome is, you still feel empowered by it. So that's really, and that goes with any choice in birth, but with this as well,
I think it's any choice in life.
Yeah, you're right.
Should be love-based.
But yeah, but
to
to prevent trauma from having a birth that wasn't the birth you want, or it wasn't one that you felt, and many people have breech babies end up with a birth that wasn't the birth they wanted, but but if it's one that you still felt that you chose, given all it was an empowered choice, that's what prevents long-term trauma. So that should be all of our focus.
Absolutely. Absolutely. I always say that the root of birth trauma is not what was done to you. It's your unmet expectations. And so getting really clear about what to expect, what's possible, who's going to help you, and making those decisions based on love and not fear is a huge, huge part of it. That's of avoiding that trauma. That's for sure. Caitlin, you're such a wealth of information. I adore you. Thank you for being on this call. Let's shift now, Anne, and let's say that this baby, that we tried everything, and now it's 38, 39, 40 weeks, baby's still breech. How do you help counsel someone about their choice? And like Caitlin has pointed out, like you've pointed out, there's a wide spectrum. We can choose to schedule a cesarean, walk into a hospital, not in labor, lay down and have our baby delivered that way, right? That can be very empowering and very relaxing for some people. Finally, the stress is over. My baby's here. Whew, I'm so glad.
Yes.
It can also be incredibly anxiety producing for some people to think of that, right? Then we can go down the spectrum all the way down to, forget this, I'm just going to stay home by myself. I'm going to do this totally unassisted. Nobody even needs to know I'm doing this. I'm going to hide from this whole experience. I'm going to be private. I'm not going to involve anyone. That can be very empowering for some people and terrifying for others. So we have this crazy wide variety, amazing amounts of different responses to the same situation by widely different people. How do we like, what do you say to someone who's in the midst of trying to figure out, I can't turn this baby, I've tried everything, or I'm due tomorrow, like I have to make a choice. How am I going to birth this baby? How do you counsel them?
First of all, you can try and know that the baby still might not do what you want them to do, right? You can talk to the baby, you can do all these activities. It might be something that's actually how your body's put together, or something with the baby where they're making this choice. They're doing the best that they can. So I tell people it's okay to try. It's very empowering to work through these processes and know that you did your very best to get what you wanted. If you do your best, you're more likely to get what you want. And when you look back on it, you'll say, you know, I really did try. There are hospitals in my area, doctors that will support vaginal breech birth. So I will give that information out freely and tell women that perhaps they'd like to go have a consult, go talk to this practice, see what's going on, see what you can do. Maybe set that up ahead of time and not wait till the very last minute for that. And then sometimes people do end up with C-sections for this. There's a whole lot. Oh, go ahead.
I was just going to say, like, I'm going to just pause on, put a pin in that statement, because this is one of the things that I feel like I want to advocate for, is that nobody ends up with a cesarean ever. That actually, it's always an informed decision, right, based on providers that are willing to sit at the bedside and talk and talk and talk through everything until that birthing person feels like they have enough information to actually make a decision. Because ending up is the language that we use in our culture that sort of gives way to the idea that somebody else is in charge.
Right.
And I know you didn't mean anything by that. I'm not picking on you at all. I just, this is the language in our culture. And I feel so passionately about, even in the midst of emergency, that the person who is most involved with the outcome is the one making the call. Right. And that's a very midwifery kind of a focus. I know obstetrics does not have that particular opinion all the time, but I think it's right. I think it's right that the birthing person, the pregnant person,
makes the choice.
They have to live with the situation. Like, right, okay, so you have a cesarean, at 48 hours you get discharged. There's no OB is going to be there helping you get out of bed to figure out how to use your stomach muscles again. No one from your surgery is going to be there helping you learn how to nurse again. Like, they don't get the right to make that call. That's my controversial opinion. Many people will birth by cesarean, but they will birth by cesarean by choice, because given all the situations and all the counsel and all the research, it was the best choice for them. That's my opinion. Yeah. So,
no, I do.
Sorry.
Yeah, I think we're all saying the same thing. And there's also that, when is a choice not a choice, which we've talked about a lot. There's when there's emotional coercion involved, when there's fawning involved, when there's not support, when there's misinformation. And I was shocked by the misinformation in terms of passing off, like guidelines as research based, when sometimes they're not. There's so much from people that really should know way better than that. So sometimes, even though it is still a choice, it's not really a choice, because they've been bullied into it, or it's based on lies or things that maybe not intentional lies, but it's based on misinformation. So it's important to hold space for that as well.
Yeah, it is. And, sorting fact from fiction is a problem we have on a global scale right now. So we're living in the age of disinformation, and unfortunately it exists in all facets of society. So we're seeing it here in obstetrics, but certainly the links that we're posting to this talk and the evidence that we're sharing cannot be misconstrued. This is true. And in terms of actually making the call, turning all the things that could turn my baby, I'm still maybe using them, but I've lost faith. I've done this for so long, or I've tried so many intensive things. It's not working. Now I have to birth my baby, because you can't stay pregnant forever. Somehow your baby must come out. You said you counsel them to look for alternatives, to have consults, to meet with people. Caitlin, what would you add to that?
Well, first I've hopefully already gone over this whole spectrum, hopefully a few weeks before. So
Yeah.
just kind of touched on it. We don't go into detail, so that they already know if the baby doesn't turn, these are my options. So usually within those, you know, and I am fortunate that often the latest that, I mean, I have had some people come see me at 41 weeks, but now I usually get referrals by like 37, but like around the time that they're, and if it's from a home birth midwife, I'm getting them at 28, 29, 30, 31, 32. So it's, I totally forgot what I was trying to say here.
It's a long conversation. We probably need to wrap up. But you were saying about
the full spectrum. So we've gone through the full spectrum. And again, I think it's really important, anybody who's working with people, that we in no way impose our agenda, especially if it's a doula, or anybody consulting, anybody doing advocacy work, that we might make a very, very, very different choice than what our clients make. And that's fine. That's we're all different, and that's awesome. And we need to,
and we all get that right individually.
Yeah, and we get to support them, whatever it is. So a lot of the things in this spectrum are things that I personally would never do. And and if there's no research based on it, if there's an increase, you know, I don't want them. I want them to make sure that they look into all of those things. We do know that there's about 10% of babies need some sort of help when they come out. So if they're even thinking about an unassisted birth, I tell them, you know, that. I tell them about resources where they at least need to think about getting an NRP class. There's all sorts of stuff. But I'm not telling them that I think that's a good idea, because that's not where I want to be. And then the other side of the spectrum would be a planned cesarean. They have so many choices with that as well. So just because they were in a hospital, just because their provider, maybe they're working with a provider who doesn't want to, if we weren't during COVID, like there's a 1 guest limit in the OR. So their doula can't come in, or their mom can't come in, only their partner can come in. So that could be something important to go over what the things that are really important for them in a planned cesarean would be. Delayed cord clamping, getting the baby skin to skin immediately. This is all assuming that the baby's fine when the baby comes out. But these are things that should be absolutely standard and options for everyone. Having no break in if you have your partner with you, even during the initial catheterization and the epidural spinal placement, and continuing having your support person with you all the way through until you leave the OR. There's many people who feel just horribly abandoned that they aren't with their partner during that beginning time and that end time. So these are
through
all
recovery, even like an hour in recovery. I mean, sometimes there's totally solitude. Yeah. There's
some places here, there's some hospitals in the Bay Area where you're alone in recovery, where it's like the partner might get in, but your doula is not even allowed in allowed. I hate that, but it's not like we can break into the recovery room. So your doula's not there. And then it's also important to kind of talk about, so you want to have a consult if you're thinking about a planned cesarean, about all of your options with that. Where is the best place for that? You still need a birth plan for a planned cesarean. There's doctors who are highly skilled in things like, and really are on the forefront of, in California especially, of things like doing delayed cord clamping, which we know is, especially if the baby might be a little earlier than the baby might have normally come out, is incredibly helpple for the baby. And
skin to skin and early breastfeeding and all these things we know. Clear to get that.
Having lights. We have one OB here that will do the actual procedure in the equivalent of candlelight, and then she turns on the lights. There's things happening places. So, and to support the providers who are doing that, and to, like, celebrate them so that they know that, that they're loved, and that that they're doing amazing work. And then within that spectrum, also, one of the things that isn't talked about kind of in the middle of that is there is an option to have a labor before cesarean, LBC. So I've worked with a lot of people who they've decided that they aren't comfortable with the research, and we could go into that too. They're comfortable with vaginal breech, so they decide that they want a cesarean, but they, for example, If someone's been struggling with fertility for a long time, is maybe knows that this is their only birth that they're ever going to have. I've had a few people, more than a few, that I've worked with that they just really, for a psychological benefit for the birthing person, forget all the great things that it can do for the baby, but for the birthing person to experience some labor. It sounds odd because a lot of people are like, why would you want to go through labor if you don't have to? But for some people, that's an incredibly important process in this journey. So the pros,
and they would be missing something really profound if they didn't get it.
So the pros of experienced labor outweigh the cons of not having a planned cesarean where you know who your doctor is coming in, because you might have whoever the on-call doctor is. So it's important that, again, there's no right choice. There's no right choice about this. It's about weighing the pros and cons of what is most important for you. And then there are some people who are just, they know immediately that if their baby doesn't turn, they've already thought about it for a while and they want to do anything to have a vaginal breech. So that does require, we go through those options, what those options are. It might mean a bunch of traveling. You know, you can have one, but you need to travel. We do have some hospital options that are wonderful in California for vaginal breech. Around here, it means
But there are many places on the East Coast where the next provider is 4 states away.
Right.
So travel is real. Yeah, for a long time, and I think still, Dr. Brad Boots Taylor in Atlanta, Georgia, took a lot of folks from a 7-state radius who would come in their RVs and wait in his neighborhood to come in and have a vaginal breech birth with him. So yeah, if that is a desire, sometimes it takes a tremendous amount of effort to get that, which is another sign that our system is so broken. But there are choices. There are always choices, is what Anne started with saying. There's always choices, even if nobody's telling you about them.
Right.
Yeah. Well, my goodness, what a fun and full conversation we've had. I'm so grateful to both of you. Anne Lundquist in Southern California, Caitlin Clarke in the Bay Area. Thank you so much for both of you to bringing your heart and your information, your education, your knowledge, wisdom to us. I appreciate you both so much.
Thank you for having
Augustine, this was such an honor to do anything with you. Is such an honor. I've learned so much from you, and I love. I love so much about what you do. But one of the biggest things is this joint commitment that we all have. Anne has it too, to professional collaboration. And to best supporting, putting kind of our whole professional ego side aside and focusing on the client as the center of care, always the client is the center of care. So thank you so much for the work you're doing in making the big changes happen that are bringing us in that direction.
Ditto, my friend.
Thank you for having me. And I feel like I've learned a lot just from being with you two tonight. Thank you.
Oh, Anne, my goodness. Well, we're so happy that Southern California has you, and I hope we get to see each other someday in the future when travel returns. Thank you both.